Hi, I'm Dr. David. I'm a neurosurgeon that specializes in pain management. Well, it appears that neck and shoulder pain is the most common type of pain on patients visiting the clinic. While it may be thought that these pains are a type of occupational disease, commonly expressed by office workers due to the rapid increase in the use of computers, they are not necessarily directly related to computer use. These pains may also have occurred in employees who used typewriters or worked with rotary phones frequently in the past. It appears that both orthopedic surgeons and rehabilitation medicine specialists commonly diagnose patients with neck and shoulder pain as having fasciitis and often treat them with injections or physical therapy. However, these treatments have not been proven effective for these pains. Some doctors also diagnose patients with neck pain as having a slipped disc and perform spinal fusion or spinal nerve blocks. Even doctors specialized in pain management often use this same treatment at pain clinics. Some places also widely use prolotherapy, a treatment that claims to strengthen ligament and muscles to treat these pains. It seems that many patients have neck that are stiff, experience pain, and have heavy or sore shoulder blade, making it difficult to move their neck front and back, left and right. These patients often use self-treatment methods such as attaching hot heat pad or massaging the painful area and seek out quick medical practitioners for acupuncture. However, these patients have not seen any improvement in their condition. The cause of such pains is not clearly visible on CT scan or MRI scan, leading to false positive findings and diagnosis of slip disc degenerative spinal arthritis or strengthening of leg of cervical bones. It is common for patients to receive physical therapy at the affected area based on these diagnoses. The cervical area has a large number of sensitive tissues in a small space that are prone to pain. Like any other spinal area, the neck region has many structures such as anterior longitudinal ligament, posterior longitudinal ligament, intervertebral joint, joint capsule, nerve root, and muscles. When these structures are stimulated, damaged, inflamed, or infected, pain occurs. Neck pain is often felt farther away from the source of pain than at the source itself. When the source of pain is in the vertebral disc or joints, skins, etc., the pain is felt directly at that location. However, when the source of pain is deep in the muscles, the pain is vague and spreads widely or is transmitted to the periphery. When a muscle undergoes tonic contraction, the internal pressure increases, leading to decreased muscle flow to the muscle and anaerobic metabolism due to oxygen deficiency, resulting in accumulation of incomplete metabolic products in the muscle and ischemic pain. In the cervical area, the posterior longitudinal ligament is strong, protecting the nerves well and preventing the intervertebral disc herniation. Even if there is an intervertebral disc herniation, it usually occurs in the lower part of cervical, so it usually causes nerve symptoms in arms and has no relation to neck and shoulder pain. Shoulder blade and neck pain are caused by muscle tensions in trapezius and multifidus, splanus capitis, and levator scapula muscles located behind the back. According to my research, pain in lower back is also due to muscle tension in the levator scapula and shoulder blade pain due to muscle tension in the trapezius. The cause of this is the muscle controlling motor nerve, the spinal accessory nerve, and the sympathetic nerve, and pain causing points in the middle and lower trapezius and serratus anterior muscles. Although neck and shoulder blades pain are similar, treatment point can be found in the middle and low trapezius and serratus anterior muscles, resulting in satisfactory treatment effect. Levator scapular muscle attached to the transverse process of the first, second, third, and fourth cervical vertebra, and is attached to the inner side of scapula. It is innervated by dorsal scapular nerve, and it helps to lift or rotate the scapula. But when the scapula is fixed, it helps to bend or rotate neck in the same direction. When both levator scapular muscles contract simultaneously, they rotate the neck bone backward. When the dorsal scapular nerve is stimulated, the levator scapular muscles contract in the posterior direction, causing the neck bone to strengthen and causing hyperdynamic neck pain. Dorsal scapular nerve is a motor nerve of the fifth cervical nerve and passes through the middle trapezius after passing near the transverse process of the fifth cervical vertebra, innervating levator scapular muscle and rhomboid muscle. Since the levator scapular muscle and rhomboid muscle are innervated by the same nerve, neck pain and pain between the scapula and neck may occur together. Rhomboid muscle is a muscle that runs from the spinous process of seventh cervical vertebra to the second thoracic vertebra, and is attached to the medial border of the scapula. It is innervated by the dorsal scapular nerve and helps to retract and rotate the scapula. When the rhomboid muscle is overused or fatigued, it can cause pain in the neck and between the scapula and neck. The miscellane muscles and the sternocleidomastoid muscle have no direct relationship. This is with scalene muscle, but they work together as a neck flexor muscles and can both cause pain when the nerves passing through them, which is the accessory nerve, are stimulated. The activation of trigger points in these muscles can cause vascular pain in the muscles, as the levator scapula and trapezius muscles simultaneously contracts and lift the scapula. When examining the anatomy, it can be seen that the nerves passing through the muscles often form trigger points for pain, and this is also the cause with the accessory nerve passing through the sternocleidomastoid muscle at the posterior margin of muscle about 3 cm below the hyoid bone. The patient's medical history and physical exam and also X-ray examination can determine whether there is any abnormality in the cervical vertebra. In the X-ray examination, the strengthening or forward flexion of cervical vertebra can be seen, which is the result of levator scapula contracting and pushing the neck forward. During the physical examination, the trigger points in the posterior portion of sternocleidomastoid muscle, about 3 cm below hyoid bone, can be found by pressing with fingers, and the trigger point in the scalene muscle near the posterior and the fifth cervical vertebra could be found. Injecting about 4 milliliters of local anesthetic into each area can quickly relieve pain by relaxing the nerves. If the local anesthetic is excessively administered or comes into direct contact with accessory nerve due to mistake of manual injection, In addition to pain relief, paralysis of the sternocleidomastoid muscle can make it difficult to tilt the neck, or paralysis of trapezius muscle can cause a loss of strength in the shoulder shrug. Acute muscle damage or symptoms caused by nerve compression or entrapment due to tension can be relieved with just a local anesthetic injection. Chronic trigger points that have caused fibrosis may require the injection of steroids, as well as drugs such as botulinum toxins, as is the cause with other pains elsewhere. When injecting a local anesthetic, it is sufficient to inject once every 2 days, but when using a steroid, it is sufficient to inject once a week. In the case of botulinum toxin, a single injection may produce a cure effect if given in an appropriate place due to the continuous local muscle relaxation effect for 3 or 4 months. Generally, when the exercise nerve is excessively excited, the muscle controlled by that nerve will cause isometric contraction instead of normal contraction, and the length of muscle will increase and the large internal pressure will rise, causing congestion in the muscle when it is in a relaxed state. You can see in this video that it is the presentation of trigger point injection with about 4 milliliter of lidocaine. Neck and shoulder stiffness, which can be considered as a modern occupational disease, occupies the highest portion of patients in pain clinics. If you understand the principle of their pain correctly, we can provide satisfaction to patients with neuropathic pain. By breaking the fixed concept of myofascial syndrome and using a method that can treat a nerve disorder, we can significantly increase the treatment efficiency.